Tēnā koutou katoa, and welcome to a lovely spring evening. Tonight we are joined by Lisa Sparks. Lisa is a diabetes clinical nurse specialist and team leader at Waitemata DHB Diabetes Service. Lisa has 15 years experience working in diabetes across primary and secondary care with a background in acute medicine. Tonight, Lisa's topic includes an overview of types of diabetes, pathophysiology and diagnosis, treatment targets and options. Guaranteed, I reckon, to be a very interesting evening. And at this point, I shall now hand you over to Lisa. Thank you.
Beautiful, thank you. Kia ora, everyone. So I'll start with this very early description of diabetes to get us started. So diabetes is a dreadful affliction, not very frequent among men. Being a melting down of the flesh and limbs into urine, the patients never stop making water and the flow is incessant, like the opening of aqueducts. Life is short, unpleasant, painful, thirst unquenchable, drinking excessive and disproportionate to the large quantities of urine, for yet more urine is passed. One cannot stop them either from drinking or making water, and if for a while they abstain from drinking, their mouths become parched and their bodies dry, their viscera seem scorched up. The patients are affected by nausea, restlessness, and a burning thirst, and within a short time, they expire. So that's one of the earlier descriptions of diabetes and really does paint quite a grim picture and a sense of hopelessness from the clinicians and the researchers of those times. We're going to just cruise a bit through a bit of the early days before we come up to today. And we think back, way back when very early diagnosis of diabetes was done by taste testers who had the job to taste the urine and decide if it was sweet. And somewhere around the mid-1800s, we worked out a way of boiling or adding acid or agents or something to urine to detect glucose. And it wasn't until around about mid-1940 that we had BM sticks. And if some of you have been around as long as I have, you might remember BM sticks. Much later, 1970, we had our first meter. And that meant that we could start doing lab testing and open up the idea of glucose challenges to diagnose diabetes. So around about 1979, we see the first criteria around the oral glucose tolerance test to diagnose diabetes. And then a little bit later, some of you will also remember this, using fructosamine to monitor long-term control of diabetes. And coming closer to today, HbA1c was introduced around about the 1980s, and more recently it became a standardized way of diagnosing diabetes. Along those times, there's been various ways of treating diabetes, mostly starvation, bit of opium to ease the pain a little bit along the way, and later on some very restrictive caloric diets. Quick overview of some of the key milestones on the journey to discovering insulin. It certainly wasn't until Banting and Best worked out how to extract insulin from the islets of Langerhans from a dog and were able to purify it that we could really use it in people and see the profound results. And these next few pictures you see, and most people are familiar with these before and after shots. The top left picture there is a young fella, Leonard Thompson. He's 14 years old in this picture, and you can just see how wasted and malnourished he is. And then, of course, later on, once he got the insulin, he did go on to live to be 26 and died of pneumonia. So there you go. Discovering insulin really did lead a way to be able to understand the difference in types of diabetes. So this fella here, Hemsworth, a physician from Yorkshire, worked out or described the different responses to injected insulin. And some people, of course, being insulin sensitive and responding, and others not being so sensitive. And this is probably the earliest documentations or understanding of insulin resistance and the differences between type 1 and type 2. We fast forward to today and we think about our definition of diabetes. We certainly have a greater understanding of the etiology and pathophysiology of diabetes. We understand that it's now a group of metabolic diseases and that there are several pathogenic processes which result in the final destination of diabetes. And this is the World Health Organization definition, which incorporates all of those processes. So we had insulin fairly early in the piece, really in the 1920s, but it wasn't until nearly 30 years later when we started to develop some tablets, and sulfonylureas and guanides being the first of those. And then there was probably quite a lull really until we found Archibos, and then things kind of picked up momentum then really. And then certainly in the last 15 years, we've seen an increase in the number of and different types of medications that we can use for diabetes. So where are we at? We've got all this wonderful knowledge about the pathophys of diabetes and all these lovely pills that we can use. But unfortunately, we're really just struggling to meet the needs of the sheer volumes of people with diabetes. So this is the International Diabetes Federation global predictive model. And you can see, I don't know if you can see there, 51% increases. It's anticipated to increase by 51% by 2045. For us, we're down here, Western Pacific region, and we're expecting that by 2045, 1 in 3 adults will have diabetes, and 1 in 3 deaths will be related to diabetes. So we've got a bit of a job on our hands. If we look at things in New Zealand specifically, this is the virtual diabetes register. And in total, we think we've got 253,000 thereabouts people with diabetes. The blue line is the old numbers. And so you can see that the newer up-to-date way of extracting this data is a little bit more encouraging in terms of how things are rising, but actually we're just holding a wait and see approach really, because we're not sure. If we look at things by region, you can see, of course, as you'd expect, most of them are in Auckland, but equally scattered amongst the various regions, and it's about a 3 to 6% prevalence in each of those populations. Canterbury, for example, probably has about a 3% prevalence, but has a lot more type 1s for some strange reason. We're not sure about, they do. Part of it is demographics, but there's some other factors there that we don't fully understand. And then, of course, Auckland has got about 6%. And then if you think about Northland, they've also got 6%. But the challenge is really about access to care and support, particularly for the rural populations and for our Māori and Pacific Island people. No surprises with the ethnicity data. We know Māori, Pacific Island and Asian groups have a higher prevalence of diabetes. Asian population tends to have better outcome though. What's becoming more and more concerning is the rising rates of multi-morbidity. So that's the presence of 2 or more conditions, long-term conditions. And it's around that, again, around access to care, appropriate access to care, and the increasing demand that it's placing on primary and secondary care. And of course, again, our Māori and Pacific Island peoples are the most affected. Now, I apologise in advance for this very busy slide. There's a lot of words in it. It really is just, it's not a finite list of all the health disparity data that I could find, but it's just a touch on some of the stuff that really does stand out in terms of health disparities. And we know that people are living longer, but actually, a greater percentage of those years gained are lived in poor health, particularly for Māori and Pacific Islanders. And of course, both populations have increased rates of diabetes. significant mortality rates, cardiovascular disease rates. Things like treatment targets for Māori men in particular, they're less likely to reach target systolic blood pressure, even if they're treated with antihypertensives and they're adherent. So that talks a little bit around monitoring and up titration and, the difficulties in engaging in rural populations sometimes. And of course, unfortunately, our Māori populations have a much higher rate of non-traumatic lower limb amputations. We looked specifically at multi-morbidity, and on the earlier side, it said there was about 25%, or 1 in 4 New Zealanders living with multi-morbidity. But actually, when you look at the Pacific Islander Māori populations, it's significantly higher. Okay, increases with age and increasing socioeconomic deprivation. And there's just a wee list there of the most common conditions. So we've got, like I say, we've got a job on our hands. And I guess the thing is that we can no longer kind of expect that people like myself sitting in specialty services take responsibility for these burgeoning numbers. And I always say the best person to look after somebody with diabetes or long-term conditions is the person that's with the patient at the time. So we all have a responsibility to increase our knowledge around this. So we'll have a quick look at some of the diagnoses and classifications and targets. So we kind of arbitrarily have these classifications of diabetes. Type 1 and latent autoimmune diabetes of the adult, also called LADA, is an autoimmune disorder and results from the destruction of beta cells. Type 2, progressive loss of insulin secretion on a background of insulin resistance. Gestational obviously is peculiar to pregnancy. And then you have these kind of weird and wonderful types of diabetes, monogenic diabetes. So one is maturity onset diabetes of the young, and the other one is maternally inherited diabetes and deafness. There is really because of the increased understanding of the pathogenesis of diabetes in recent years, there's been a call to view diabetes more as a spectrum or a continuum of metabolic, genetic, and immune pathologies. I'll talk a little bit more about that. This particular diagram I quite like. It probably looks a bit busy for you guys, but this is a model that was presented in Diabetes Care in 2016. And what it does is it really just recognizes those 11 interlocking pathways that lead to diabetes. So it recognizes the genetics around whether it's type 1 or over here MODY or some of those monogenic types of diabetes. It recognizes the metabolic influences that occur in diabetes, as well as this kind of immune dysregulation that can happen. But as well, it thinks about age, insulin production with the C-peptide, level of inflammation, because if you've got high blood sugar levels, it precipitates inflammation. And also thinking about how best to treat it. Now, the reason I find it so useful is because less and less I'm able to categorize people into either one or two camps, type 1 or type 2. They might fall into that camp, but there will always be some level of metabolic or inflammatory markers that are playing some kind of significant role that will influence how I'm going to treat somebody and the treatment choices, and environment will always play a key role in what's happening. So we may find moving towards the future and in space age times that we might be treating diabetes very, very specifically in a designer kind of way when we dictated by genetic or metabolic testing. Maybe in my lifetime, but for now, we're still working with the classical definitions of diabetes. And so what you see here is your diagnostic criteria. Now we can diagnose still on fasting blood glucose or postprandial or HbA1c. And in the presence of overt symptoms, it's one test. If there are no overt symptoms, you need to repeat the same test. There's very low concordance between tests. That's why if you've started out with a fasting glucose, repeat a fasting glucose. If it's a HbA1c, repeat a HbA1c. In terms of value of various tests, HbA1c or glucose, for somebody with acute onset type 1, a glucose level is a much stronger predictor. So that was just useful information. We've got to remember though, things just are not always as they appear. And this is why I say the continuum of diabetes, we need to start thinking of it, of all these things influencing each other. Because sometimes type 1 doesn't come on quickly, it comes on slowly, and there's this steady decline in beta cell function. A third of people with type 1 diabetes will present with life-threatening ketosis. Obviously, it means that 2/3 won't, so that may not be a clear way to diagnose type 1. And a third of people with type 2 can present with a level of ketosis. So it's kind of flipping things on its head a wee bit. And often in type 2, it's around glucose toxicity. So if your blood sugar levels are so high and your pancreatic beta cells are swimming in glucose, it really impacts the ability to produce insulin so you become ketotic. But as soon as you add in a bit of insulin, it can all settle down and reverse. So some flags around type 1 diabetes. So if you've got someone who's not really fitting the conventional picture of type 2, if they're slim, if they've had a recent history of significant unintentional weight loss, positive urine or blood ketones, blood sugar levels greater than 15, an unclear family history. Usually you can track type 2. There's some clear family history. Type 1 tends to kind of skip generations, appear in second and third degree relatives. So if there's some inkling that you might think this could be type 1, and also there's some present of other autoimmune disorders, thyroid, celiacs, then potentially this could be type 1. So you would check some autoantibodies, some GAD, IA2 antibodies, and possibly C-peptide, which will give you an indication of insulin production. For these weird and wonderful genetic types of diabetes, it's really around the age of onset. So if there's a kind of pattern within a family of a number of people developing diabetes under the age of 25, then it should flag something in your mind that this seems a bit unusual, and maybe this is a genetic form of diabetes. Also, if there's familial diabetes and there's deafness, maybe this is mid. All of these people go to specialists and get genetic testing. So who should we actually be screening? Well, this is an ADA picture, and even though it's an American Diabetes Association picture, it really does apply wherever you are. And although it says, you know, every 3 years, if somebody has one of these flagged every 3 years, they should be checked for diabetes. If they've got more than one and the risk is higher, then we would do it more frequently. Okay, and of course, if you've got people that present with symptoms, osmotic symptoms, recurrent infections, particularly thrush or UTI or skin infections, then a check for diabetes would be indicated. And that can just be a HbA1c. So moving along to treatment targets, how we decide, you know, how tight a control somebody should have was really dictated by two landmark studies. One was a UK PDS and another DCCT. And they're both randomized controlled trials. They randomized patients to either intensive management or conventional management at the time. And it clearly demonstrated that 53 millimoles per mole was the magic number to reduce long-term complications of diabetes. For many years, though, the risk of hypo was a barrier really to tight control. But since then, we've had a number of other stories, but it really hasn't shifted that target too much. So we had the EDIC trial. So that was a cohort trial that followed the group from DCCT and just observed them after that trial had ended. And basically that showed that there was some level of legacy effect. So that if people have had tight control early on in diabetes, they still have less complications later on, even if the HbA1c has deteriorated over time. And there was a number of other trials around cardiovascular risk, particularly when we got the new analog insulins, so your Humalog, Apidra, Nova Rapid, with a less or lower risk of hypo. The question was asked, could we improve targets to a lower level and improve outcomes for people with already existing cardiovascular disease or high risk? And actually what it showed was a reduction in HbA1c, and that cohort actually precipitated cardiovascular events. So it was a big no to, tight control. So off the back of those trials, the ADA said, oh, actually we need a consensus statement. So they came up with this algorithm of how to decide what would be a patient-centered target for somebody with diabetes. And the range in today's numbers, that's old money up there, 6% to 8%, is 42 to 64. The lower target of 42 is really only achievable if you have somebody who's on medication that does not cause hypoglycemia. Otherwise, 53 would be your target. And you kind of work through this kind of process of looking at how motivated and capable is the person, how long have they had diabetes, what is their life expectancy, do they already have existing conditions that are going to increase their risk if we tighten up control, and should we be controlling their blood sugar levels tightly or not. And we do get patients, I'm sure you can think of many, where we'd love to have them at 64 millimoles per mole, but they just can't quite get there. And so that's why we have to really think about matching it to the person. Cardiovascular risk reduction is important. And, even modest improvements in HbA1c can bring about some profound reductions in all of the outcomes of diabetes. So going from 90 to 80 or 80 to 70 is still improving outcomes in those groups that find it difficult to get lower levels. But it's not all about HbA1c. As I said, cardiovascular risk management is important. It's important to think about blood pressure and lipids and introducing the right medications at the right time. And we think about things like statin and ACE, and we call that dual therapy. When should we think about dual therapy or triple therapy? When should we add in aspirin as well around managing cardiovascular risk? And increasingly, we're starting to think about various oral and injectable agents that have been identified as having positive effects on cardiovascular outcomes and renal outcomes. So it gets quite complicated as you move through it. So we'll have a quick look at blood pressure and lipids and aspirin. So blood pressure for people with diabetes is 130 over 80. So anybody above that or has a cardiovascular risk greater than 15%, we should really be thinking about adding in an ACE usually, or an ARB for people with diabetes, because we know both of those are renal protective. In the normotensive patient, so the patient has good blood pressure but has an elevated urine microalbumin or ACR, we should be adding in a small dose of an ACE or an ARB, because we know it will slow progression to overt proteinuria and CKD. We do need to think about the impact of hyperglycemia on elevated urine microalbumin levels and lipid levels. We know that high blood sugar levels will drive up triglycerides, so it will impact the lipid profile, and it will increase inflammation in the kidneys and increase in urine microalbumin levels. So we need to think about that and whether what is the likelihood of somebody improving their control, and that might improve things, or how long has this been going on for? What is the risk, and should we treat it anyway? Cardiovascular risk and lipid levels really guide your introduction of statins. So again, this is the new criteria, over 15% cardiovascular risk, we want people to start on statins. And I kind of have quite a low threshold for that intermediate group, between 5 and 15%, particularly in people with diabetes. Aspirin's kind of been thrown out, really, almost, nearly. It's just sort of hanging in there. So we only really recommend this in the over 15% group. And of course, we know that if somebody's had a cardiovascular event, they should be on some sort of antiplatelet therapy anyway. Yeah. And no aspirin for the over 70-year-olds. This is a bit of a random slide, which I always like to throw in, because we should know how to do a good foot screen. About 50% of our people with peripheral neuropathy will have no symptoms. So I can't really stress the importance of being able to check feet at least once a year. And if somebody's already had some kind of abnormality in a test, then we should be doing it every 3 to 6 months and having a good look at feet. So here we go. We're getting to the business end of things here now. This is our armament of orals and injectable agents. I'm going to apologize in advance because the slides coming up, I've created tables for each of these medication groups, and I have tried to summarize how they work, you know, what the benefits are about them. And because we've got so much more knowledge about these things now, there's a lot of information in these slides. So yeah, I apologize in advance. And you know, in the past, I don't know if you will recall that we had pioglitazones introduced. So they're the TZD group here. That's quite a number of years ago now. We thought they were going to be the next best thing. And there was quite a few side effects with them, and particularly with the predecessor, rosiglitazone, caused some issues with cardiovascular risk and heart failure, which really shook up the diabetes community. And so what came from that was this impetus to say that all medications that we use at the very least should have a neutral effect on cardiovascular outcomes, but ideally have some kind of benefit. So what that did was make the scientists go back and really look at some of the medications we currently had, think about what was coming up, and identify where they fit in terms of treating our patients. So metformin, an oldie but a goodie. It's been around a long time, and believe it or not, we kind of don't really understand how it all does what it does, but it seems to do some wonderful things. So it's an insulin sensitizer, and we know that it reduces gluconeogenesis. It somehow interrupts the lactate pyruvate alanine pathway, so that energy production, and kind of switches metabolism from aerobic to anaerobic. So it increases the conversion. You don't need to remember all this, it's just nice to know, stuff of glucose to lactate. Now, that little gem is probably quite important, because when lactate is usually just cleared without any problems, but when our renal function starts to deteriorate, it hangs around a little bit longer and can cause some problems with metformin. There's some emerging evidence about metformin that suggests it increases the level of a hormone called GLP-1, which we'll talk about in more detail later on. GLP-1's pretty cool. It tends to coordinate first phase insulin response, so that's insulin produced before our blood sugar levels have even begun to rise. It tells our brain we're full when we're full, which is really handy. It makes us stop eating. and you know, overall reduces insulin resistance. There's some other evidence that metformin may improve mortality in cancer. So there's lots of new stuff coming out about metformin, but essentially we think about it in terms of reducing peripheral resistance, insulin resistance, and decreasing gluconeogenesis. In terms of efficacy, it can probably drop HbA1c around 10 to 20 millimoles. Main side effects are gastric, so we usually start with a low dose and titrate up, make sure that it's taken with food. We do need to be aware around that lactic acidosis risk, that reducing renal function means we need to reduce the dose of metformin. And certainly once an eGFR gets below 30, we probably should be thinking about stopping it. There's an increased risk in acute illness as well around lactic acidosis. So in the acute setting, we need to think about sepsis or use of IV contrast or exacerbation of congestive heart failure and whether metformin should be stopped. There's a few tablets that tend to exacerbate the GI symptoms, just something to be aware of. B12 probably doesn't get as much attention as it should. Long-term use of metformin seems to make people deficient in B12. It's certainly important in people with peripheral neuropathy or painful or symptomatic neuropathy, because if you've got a low B12, it's going to exacerbate those symptoms. And of course, in anemia and cognitive dysfunction, we want to know what's happening with the B12. In terms of how cool it is and in other aspects of its job, it's weight neutral. We used to say it made you lose lots of weight, but maybe up to 4 kgs, but essentially it's weight neutral, reduces triglycerides and LDL and increases HDL, has some kind of positive effect on CVD overall. PCOS, it lowers androgen levels, so it increases fertility, safe in pregnancy, and as I said, it's implicated in reduced incidence and mortality in cancer. A bit more research needs to be done around that. So it's pretty cool, and people are starting to relook at it. Sulfonylureas, they've been around forever, as you know. We think of them as secretagogues, or we call them secretagogues. They tell our bodies to make more insulin, and they do this really by attaching to this wee receptor site on the side of a potassium channel on pancreatic cells, which causes the channels to close and depolarizing the cells, so that because of the positive potassium ions, which then causes the wee calcium channel up here to open, you get this big influx of calcium, which then signals the release of insulin. Pretty cool. So it's a secretagogue. It lowers blood sugar levels fairly well, anywhere from 5 to 15 millimole drop in a HbA1c. We start low, we titrate up. Somebody's got a high HbA1c, start with a higher dose. If they're kind of close to target 64 millimoles, we might start with a lower dose. Main risk is hypo. Weight gain associated with them, and that's just to do with the absorption of circulating glucose. Higher the HbA1c when you start, the greater the weight gain. Avoiding sulfur allergies. Some rare side effects, to be fair. I've never seen intrahepatic cholestasis. I've seen skin reactions every now and again. Yeah. So that's them. The main issue around sulfonylureas is that they can promote beta cell exhaustion. So they wear out the pancreas faster. They're neutral on CVN renal outcomes. So there's probably better drugs now that have more benefits. So PIO, oh bless. So PIO does so many wonderful things, but it's got such a bad reputation, and it is quite a complicated process by the way it works. It does reduce insulin resistance, and it reduces gluconeogenesis at the liver level. So it also seems to, from that point of view, have an effect on lipids and inflammatory markers. It's what we call a PPAR gamma agonist, and so it seems to impact the way that fat cells are turn over. So it tends to expand what we call white fat, which is the good stuff, which will pick up detrimental fats that are circulating in our system, and it tends to draw out some of those bad fats that's sitting in our viscera. So it's positive from that point of view. It impacts mitochondria directly, and it, in a similar way to metformin, seems to have an impact on how cells utilize energy, and through that mechanism it tends to reduce the amount of gluconeogenesis, and overall that just results in increased insulin sensitivity. And there's some pretty groovy bits of research going on around its effect on inflammatory markers and vascular endothelial growth factors and stuff like the diabetes specialists love to get their teeth into, because those are the things that stop retinopathy and stuff like that. So here you go, we start low and we move up. There is this issue around fluid retention. That's really, you know, it has direct effects on the renal tubules, and they tend to retain a bit more fluid, but it's dose dependent. So if you're concerned someone might retain fluid, start low and titrate up. It takes a little while to get to maximum effect. So you need to tie-ho a little bit before you titrate up, just to see how things are going. Can improve HbA1c quite significantly. There's conflicting information out there around whether it will make liver enzymes worse or make them better. In theory, if it's pulling out fatty deposits from your liver, then it should make them better. But some places you read will say then it'll make it worse. So the answer is monitor your liver function tests, I think. There's some definitive risks around osteoporosis and increased fracture risk in women, particularly post-menopausal women, so we don't tend to use it in that group, and we certainly wouldn't want to be using it in heart failure because of the fluid retention. Little asterisk there next to bladder cancer, because in preclinical studies it showed that there was bladder cancer just in male rats, not in any other animal and not in the female rats, just in the men. So there's a little asterisk there to say that we wouldn't give it to people who had a history or had active bladder cancer. Macular edema is a rare side effect. I haven't seen it, but if someone was to complain of new blurred vision after starting PIO, then we would want them to have an ophthalmological exam. Big word for this time of night. No, I think it's only partially reversible, so it's quite a significant side effect if it happens. So we wouldn't want to muck around with it. But saying all that, it has some wonderful things about it. It reduces serum triglycerides, it increases HDL, it pulls out fat from the liver, so it can be very useful in non-alcoholic fatty liver disease, and which is actually receiving a lot of focus at the moment because we kind of ignored it and didn't really think of it as too much of a thing. But actually, you know, it can cause significant liver damage, so there's a lot more focus on that. It can lower blood pressure by about 4 millimeters of mercury, seems to reduce urine microalbumin, and has clear beneficial effects on cardiovascular disease, and it shows reduction in major adverse coronary events, or MACE. It does show some benefits in PCOS, but it's actually a category C drug. It means, you know, it can have some detrimental effects on a fetus. So probably not a good idea to use it in that context. All right, So here we are with Archibos, probably one of the most simplest medications ever. It really is just, it's a competitive inhibitor of pancreatic amylase and glucosidase. So basically, it blocks at the gut level the breakdown and ingestion of carbohydrates. It does not block lactose though. So that's just something a weird thing to remember, because lactose or milk sugars will be absorbed and impact blood sugar levels. And it seems to, because it has this kind of blocking effect and causes this kind of filling effect in the tummy, influence GLP-1 release as well. So we're going to keep hearing this GLP-1 coming up over and over again as this kind of new wonder thing that's going to happen. We don't use it a lot, and the reason why we don't use it a lot is because the carbohydrate sits around in the gut, it degrades and it makes people bloated and windy and they get diarrhea, and generally it's a fairly antisocial medication and it's a weak agent. But I do have a handful of patients on it. I find that Asian people tend to tolerate it. I don't know if that's the right word, I think that perhaps there's less social taboo about flatulence in those communities, so they will happily take it. So the dose can be very dependent on carbohydrate consumption. It tends to have a significant impact on postprandial or post-meal glucose levels. Contraindicated in liver problems, GI diseases, as you'd expect, and we wouldn't give it to people if they didn't have decent renal clearance. It's weight neutral and possibly teeny weeny bit of weight loss. It really doesn't have many benefits in terms of cardiovascular risk or renal outcomes. Might be beneficial in pre-diabetes. So like I say, it's not something we use a lot. So gliptins, these are the new drugs on the block, and we're using them everywhere now. So gliptins basically, vildagliptin, block or inhibit the action of this thing called DPP4. So what that means is when we eat, stomach stretches, we release GLP-1, that's that groovy thing that helps us feel full and delays gastric emptying and tells our pancreas to release insulin, which stops glucagon from working and increases cellular sensitivity. When our bodies are finished with it, this stuff called DP4 comes along and tells it to break down and switch off. So what Vilda does is blocks this, so that somebody's GLP-1 works a lot longer. That's pretty cool. So it's not a super duper strong agent, 5 to 10 millimole reduction in HbA1c, but we've got a combination pill, which is pretty cool. Means we can add it with metformin. It's only one pill. Fairly well tolerated. I haven't yet had anybody have a hypersensitivity reaction or complain of headaches. I've had a couple of people in hospital with pancreatitis, and I've had one person with this very rare kind of blistering side effect called bullous pemphigoid, but by and large it's very well tolerated. We don't give it to people with very low EGFRs, but we can reduce it in an EGFR of 60 to 1 tablet rather than 2. It's weight neutral. It might reduce systolic blood pressure, not very much, but a little bit. It's neutral on cardiovascular outcomes. It probably or maybe reduces urine microalbumin, but has no effect on EGFR. So this is the injectable GLP-1, which essentially does everything that DPP4 does by blocking, and prolonging the action of GLP-1, But in addition to that, it has this kind of effect on our brown adipose tissue. And so brown adipose is all about heat production. And so it increases this thermogenesis, which essentially means we're burning up and getting rid of some of the not so nice fats that are circulating in our bodies. So that means it's got this huge list of positive effects. And I got word today actually that we are going to have a subsidized GLP-1 by the end of this year. It's not going to be either of these. I took a punt 2 days ago thinking it could be one of those two, but it's neither of those. It's actually, she says, looking at a little bit of paper, something called dulaglutide. So that's watch that space. As soon as Pharmac and MedSafe approve it, it will be available. So again, it has quite a significant impact on HbA1c. Main side effect is around the GI, as you'd expect with slowing gastric emptying. People are going to get some symptoms, but it generally settles. And there's some issues here we just need to be aware of around gallbladder or gallstones, and there has been some preclinical, subclinical and increase in pancreatic enzymes. So we're just a little bit wary around these groups. And then we've got this funny little thing about thyroid cancers that appeared in rats again, but no other animal and not in people, but it just makes us have a little flag there that we're not going to use it in that situation. So these are the list of all wonderful things that it does. Weight loss, huge range. Now the literature says like really low numbers, 2-4 kgs, but actually I've experienced it much higher. You can't really predict it. You can't look at somebody and go, I know they're going to have loads of weight loss. It's an unusual thing. We worked this out earlier on when we were using Byetta. It reduces blood pressure significantly, also seems to have a significant effect on heart rate, albuminuria, cardiovascular events and mortality. That NAFLD thing again comes in, and we know that it has possibly some prevention around admissions for congestive heart failure. I think this might be the last one for all the medications. SGLT2s are coming too. I also got a notification about that today. That's something called empagliflozin. They never make them easy. Will be available around about October time. So what these things do is they actually block the action of this thing called SGLT2, which is a glucose transporter, which basically makes you keep in or retain your glucose. So if your blood sugar levels are 10 or less, you will hold that glucose in your body. This medication lowers that threshold, so you pee out more glucose, and it can actually mean that you're peeing out 60 to 90 grams of glucose a day, which is quite a lot. It will vary based on renal function and the level of hypoglycemia, of course. And if it's causing that kind of glycosuria and osmotic diuresis, it's pulling fluid with it, there is a level of sodium loss, just something to be aware of. But it also means that it has some really cool benefits. So it's not a hugely strong agent, 4 to 10 millimoles. And we do need to be clear about assessing renal function and volume status, because people are going to lose a bit of volume when they're on this medication. But it has significant effects on blood pressure. It has significant effects on heart failure, mortality and hospital admissions, decreases cardiovascular disease, probably will promote some weight loss. It will pull out some fat from our liver. And so it's doing some really cool things. Side effects, UTI is a side effect, but it's not consistent across the studies. What's more common is genital mycotic infections, so balanitis or vulvovaginitis. Of course, there's risk of hypertension and hypovolemia, so we just need to be aware of that in some populations or people who are naturally hypotensive. And then we just also need, oh, sorry people, we'll go back. Need to be a little bit aware around the risk of ketosis, because if somebody's blood sugar levels appear lower, if somebody gets ketotic, one of the markers is high blood sugar levels. But if you're peeing out your glucose, it may not necessarily flag that you're producing some ketones. So there is a risk of ketosis with this medication. Okay, if somebody's EGFR is low, then it's probably not going to work very well anyway, because it's dependent on having good flow through your kidneys. So how well medications work kind of varies, and what we tend to see is that the higher the HbA1c, the greater the efficacy of the drug, and there's that linear relationship. But we need to be aware, though, with very elevated HbA1cs, particularly in the absence of significant dietary simple sugar intake, or in the absence of adherence issues, then it likely indicates the need for insulin. Okay. This very busy slide is really just saying how complicated our decision making has become about which agent we're going to have when. And very soon, I think once we get both of those newer agents subsidized, we'll see an algorithm just for New Zealand, which probably will look much simpler than this American one. So what does it all mean? What do we do with all this gorgeous knowledge? Basically, metformin at diagnosis along with lifestyle changes. Don't wait for lifestyle change, just stick the metformin in straight away. Vildagliptin, or for those with no cardiovascular disease or renal issues, or have low risk of cardiovascular disease and renal issues. We start thinking about one of those wonderful dapagliflozin or empagliflozin, which is the one we think we're going to be getting in New Zealand when somebody's got a high cardiovascular risk, or they already have cardiovascular disease or early renal disease and heart failure, because we know the benefits are greater in those groups. Pio is still an option. It's still there, despite the fact that it's got these side effects. It does have some good benefits too. And so particularly for men with a bit of central adiposity, a bit of extra fat around the middle, and likely to have a bit of fat sitting in their liver and be very insulin resistant, but no history of heart failure, is still useful in those groups. Glycoside or insulin, our patients tend to want to stay on pills, so I think there'll always be a place for glycoside and glipizide. But in terms of protecting our beta cells, it would be better to go straight to insulin, to be fair. So this is a very busy chart again. If you get time to look through it, but this is kind of how we go about insulin and type 2 diabetes. There's probably a whole webinar by itself, but it's straight from the ADA. Essentially, first line insulin for type 2 failing on orals or GLP-1 would be Lantus, NPH or Protophane, and that's to correct fasting glucose levels. And then followed by the introduction of a rapid acting insulin, usually at the largest meal. So most frequently that's the evening meal, and we might add in a Peda or Humalog and Nova Rapid, it doesn't matter. Or we might decide to give a biphasic or a mixed insulin Nova mix or Humalog mix at that evening meal. Once we add in rapid acting insulin, we start to withdraw the sulfonylurea medication. Okay, and dosing is usually around 0.2 kg per kg per day, but really the trick is just to start low and make sure you titrate till you get there. Type 1s, I think, are so much easier. They're so simple once you've meandered through all those medications. They require dosing based on kg, unit per kg. We split their dose 50% between background insulin and meal-related insulin. If they've got higher levels of growth hormone, like we would if we're in puberty or in periods of significant growth, then they require more. And of course, this is all matched alongside with some very good education around carbohydrate counting. So the last couple of slides are really just looking at what works for this, you know, in managing long-term conditions. And I think the main thing is that we must be targeting aspects of disease burden. And we know that the burden of disease increases with the number of long-term conditions somebody has. It increases with the number of medications and the complexity. And as it increases, self-efficacy and adherence will go down. So whatever we do, we need to have some kind of approach around supporting people and navigating this burden of disease that they're feeling. We need to think about specific goals and targets. What actually are we trying to achieve? And particularly targeting risk populations, and we've touched on some of those tonight. Whatever we do, we've all got to be talking to each other. Otherwise, things will fall over and we'll disconnect and potentially not get the best outcomes. So integrated and shared care and formal case coordination is really, really important. Some of the components of our interactions and our education with our patients really need to focus on self-management and what they understand about their disease, its treatment and its process, what they can do themselves to improve that. Understanding medication is so important. I've lost count of the number of times patients have come to me and they really have no clue about what their tablets do. And I'm sure if they did know, then they're more likely to take them. Psychological support can't be underestimated. The prevalence of anxiety and depression related to the burden of long-term conditions is huge. And of those carers who are looking after sometimes multiple family members who are unwell need that support. So the last slide that I've put in is really just kind of trying to bring all those things together around the patient and how we might approach this. So hopefully there's a few of you out there who are doing some nurse-led clinics around diabetes and long-term conditions. And this is hopefully something you might find useful. And I think that's it. So we're all good for questions. Wow,
that was wonderful. Thank you, Lisa. I knew you were bulging with knowledge. I could just see it in your eyes. So far what we've got for you is just one question. And so we've got, using the Freestyle Libre, the glucose meter has proven to be a successful measure that's helped reduce HbA1c levels. Why is it not funded yet by the government?
Good question. Oh dear, I don't think it works for everyone. I think there's particular people who are very motivated and it works really well for. So I think we're having issues with really trying to argue about bang for buck to Pharmac around that. There are other CGMS monitors that are more accurate and reliable, that are sort of sitting there in the background, which are competing a little bit. There are issues with CGMS in low and high ranges around accuracy, so that potentially might be influencing decisions. But I agree, anything that, you know, means that people don't have to prick their fingers a million times a day to achieve control, and have that control to be able to see predictively when their blood sugar levels are falling and do something about it, has got to be a good thing.
And I got a couple of people saying how great the presentation was, and just like you said, there's quite a lot of information on some of the slides, and just wondering if you'd be willing to share your slides with Mobile Health so as that they can digest them at leisure.
Absolutely, no problem.
I figured that would be a yes, but still, there we go. And other than that, there's just messages starting to come in about how great your presentation has been, and thanking you for your time this evening. There's
Well,
been a
that's
good
good
number
then.
of people from across New Zealand log in to listen to you. Quite a few from Timaru. I think they take the prize tonight for having the most people from one area.
Oh, well done, Timaru.
Yes. So no, that's absolutely fantastic. Thank you very, very much, Lisa.